Today, we are on site at the Moscone Center in San Francisco, California at the 2020 Genitourinary Cancers Symposium. We'll be recapping some of the top news presented each day during the meeting, and soon we'll speak with Dr. Mary Ellen Toplin on some of the biggest updates in prostate cancer and Dr. Sam Hobday on some of the top bladder cancer abstracts. Welcome to OncLive News Network. I'm Gina Columbus. In prostate cancer, a randomized phase 2 study evaluating sipuleucel T with radium-223 dichloride showed that the combination led to improved clinical outcomes compared with sipuleucel T alone in patients with asymptomatic bone metastatic castration-resistant disease. Due to the fact that neither sipuleucel T nor radium-223 elicit prostate-specific antigen responses, the findings suggest that the combination may have a synergistic effect. In a cohort of the phase 1b COSMIC-021 trial, the combination of cabozantinib and atezolizumab demonstrated clinically meaningful activity in patients with metastatic castration-resistant prostate cancer, including those with high-risk clinical features. Results showed that the combination elicited an overall response rate of 32%, including 2 complete responses and 12 partial responses in the overall cohort of patients with mCRPC. In a subgroup of patients with high-risk clinical features, which included those with visceral metastases and/or extrapelvic lymph node metastases, the ORR was 33%. In metastatic castration-sensitive prostate cancer, a post-hoc analysis of the phase 3 TITAN trial showed that the addition of the anti-androgen apalutamide to androgen deprivation therapy leads to a reduction in the risk of second progression, regardless of whether patients receive hormonal therapy or a taxane as their first survival-prolonging subsequent treatment. The TITAN trial previously demonstrated an improvement with radiographic progression-free survival and overall survival when adding apalutamide to ADT in this patient population. Based on these initial data, the FDA approved apalutamide in September 2019 for the treatment of patients with metastatic castration-sensitive prostate cancer. In the multi-cohort phase 2 KEYNOTE-199 trial, combining pembrolizumab with enzalutamide showed modest anti-tumor activity in patients with RECIST, measurable, and bone-predominant metastatic castration-resistant prostate cancer. In the 2 cohorts, the androgen receptor inhibitor and PD-1 inhibitor regimen also had a manageable safety profile. The combination will now be evaluated in a phase 3 trial. Finally, an analysis of the CARD study showed that cabazitaxel was linked with a greater pain response and a delay in pain progression compared with an androgen receptor inhibitor in patients with metastatic castration-resistant prostate cancer. While both agents were associated with similar trends in health-related quality of life, the functional assessment of cancer therapy prostate deterioration was longer with cabazitaxel compared with an AR inhibitor. We are here with Dr. Mary Ellen Toplin, who is a professor of medicine at Harvard Medical School and Dana-Farber Cancer Institute, to discuss some of the really exciting prostate cancer abstracts that are being presented here at this year's meeting. Hi, Dr. Toplin. Thank you so much for being here this year.
My pleasure.
So, it's been a really exciting year so far for genitourinary cancers. So, looking at the prostate cancer studies being presented here this year, what are you most excited about?
I'm excited about a lot of things. Particularly excited about all the new clinical trials. So the section of clinical trials in progress is wonderful to see all the new drugs in evaluation and the new pathways and the correlative science to help us understand how treatments are working and not working. So it's future data, but it's exciting work to come. And patients are always asking us, what's new, what's in testing, and so that group of presentations is I think, very appealing.
Absolutely. Now, there's a trial looking at the combination of sipuleucel T with radium-223 dichloride in metastatic, asymptomatic bone metastatic castration-resistant disease. So, can you discuss the rationale for this combination and what the findings look like for this study?
Sure, I'd be happy to. It's a very small study. 2 companies came together. Dendreon and Bayer, and this is a trial that's run out of Johns Hopkins, and 32 patients, so small, were randomly assigned to either sipuleucel T alone or sipuleucel T and radium. And interestingly, there were some very good responders in the combination group, both in terms of PSA response and radiographic progression. Now, it's a very small study, and I think we need to curb our enthusiasm a little bit and see what a larger data set will look, but it would be, it's very promising. You know, it's based on the rationale that the radiation from the radium can expose antigens and prime the immune system for a treatment like sipuleucel T. So very rational design and exciting early data.
Good, thank you.
Yeah.
So apalutamide is another anti-androgen that has garnered a lot of interest in prostate cancer. And this year we're seeing an analysis from the Titan trial looking at PFS2 and metastatic castration-sensitive disease. So what additional data have we learned with these results from this year?
Well, today they presented an exploratory endpoint called PFS2. The definition of PFS2 is at the time of entry into the trial, patients are followed through their response to either apalutamide or placebo, and subsequently through their response to the next treatment they get, whether that's another hormone therapy or another chemotherapy, and then looking at that time. So they presented today on a small number of the whole cohort of patients, only about 270 patients, and it looked like the PFS2 certainly held up with the apalutamide group compared to the placebo. Now you might expect that to anyway, it makes sense because they're getting an extra therapy, the apalutamide, as opposed to placebo. And I think the caveat with this one is there's very few events so far that can be measured. And so I think this is the first we're going to hear of this data, and really to synthesize it and feel good about giving earlier treatment that will correlate with PFS2 and overall survival. We need another year or two of data. But it's very good early look, I think, at that trial.
Wonderful, thank you. Now, before you were talking about some of the clinical trials in progress, and this year you're actually presenting on the Proteus trial with apalutamide in localized high-risk or locally advanced prostate cancer. So what are the goals of that trial, and can you give us some background to it?
Sure. So prostate cancer is one of the few cancers where we haven't proven with data that combining systemic therapy with surgery improves outcomes. So this trial, called the Proteus trial, is the first large phase 3 neoadjuvant trial in 12 years in localized high-risk prostate cancer. So based on some preliminary data from a series of phase 2 trials looking at intense hormone therapy prior to prostatectomy, this trial was designed, and we're evaluating standard hormone therapy plus apalutamide with standard hormone therapy for 6 months before prostatectomy, followed by another 6 months after prostatectomy. And then there's co-primary endpoints in terms of the pathology from the prostatectomy specimens and metastasis-free survival. So if this is a positive study, it could prove that the pathology, the early endpoints are valid for larger, longer down the road clinical endpoints. It could really open the door for a lot of other good work to be done in this space. And the exciting news about this trial is it's accruing much quicker than we had even projected. It's very well received by patients and treating urologists and medical oncologists around the world. So, it'll take 2.5 years to accrue and another couple of years to follow, but we're really excited that this trial is getting done so quickly.
That's wonderful. It sounds like a really interesting study.
Yeah.
So looking at the data that we're seeing obviously presented this year, what do you think the future holds for prostate cancer by the end of 2020?
By the end of 2020, so 10 months from now.
Yep.
I think that as far as treatments in the clinic, things don't change that rapidly, unfortunately. I think the recent advances of understanding DNA repair alterations in prostate cancer, developing drugs in the PARP inhibitor group has been exciting recently for prostate cancer. I think we're going to learn more about that group of patients, who are the exceptional responders versus non-responders. The newer hormone drugs have been around now for 10 or more years, but we're learning how to use them earlier in various contexts, non-metastatic prostate cancer, hormone-sensitive prostate cancer now with surgery and radiation. So I think that work will continue. But what excites me is like the really early drug development, the new pathways that we're looking at, and I don't think those drugs obviously will come out in 2020, but we may get into like deeper phase 2 studies and more of a sense of what's working.
Dr. Toplin, thank you so much for being here today. You shared some wonderful insight and some really exciting data too, so thank you so much. Appreciate it.
You're welcome. Thanks a lot.
Hi, we are here with Dr. Sam Hobday, who is the Bladder Cancer Director at Dana-Farber Cancer Institute. He'll be talking with us about some of the top bladder cancer abstracts being presented at this year's symposium. Hi, Dr. Sam Hobday. Thank you so much for being here today.
Thank you.
Great. So, you are actually chairing one of the rapid abstract sessions this year for urothelial carcinoma. So, what are some of the studies that we're going to be hearing about this year in that session? What are you really excited about?
There's one study that I really want to highlight, which is the study that looked at the combination of enfortumab vedotin and pembrolizumab as first-line treatment in metastatic urothelial carcinoma. And these were patients who were not cisplatin eligible. So this was a small study, modest-sized, non-randomized study of around 45 patients. And the exciting thing about this study was the high response rate. The response rate was like 73%, including close to a 15% complete response rate. And the responses were seen regardless of PD-L1 status in the tumor. So this was a really highly promising regimen, in my opinion. The toxicity profile was manageable also, and as expected, and nothing prohibitive was seen. So I'm very excited about the potential for this antibody-drug conjugate enfortumab vedotin in combination with pembrolizumab.
Definitely. Now, there's also the BLAST-1 trial, which is looking at nivolumab, gemcitabine, and cisplatin in patients with muscle-invasive bladder cancer who are undergoing cystectomy. So could you kind of give a little bit of overview of that trial and why it's important?
Right. So this is a study in which I was involved. This was a non-randomized phase 2 trial that combined the standard chemotherapy of cisplatin plus gemcitabine in cisplatin-eligible patients as neoadjuvant therapy for muscle-invasive bladder cancer, and combined nivolumab, the PD-1 inhibitor, with gemcitabine cisplatin. Again, this study was a modest-sized phase 2 study in about 41 evaluable patients, and the exciting thing was that around 65% of patients achieved less than muscle-invasive disease, non-muscle invasive or complete pathologic complete remission with gem-cis plus nivolumab. So this is again an exciting combination of a checkpoint inhibitor, nivolumab, plus cisplatin-based chemotherapy. And also I would add that a phase 3 trial is ongoing to validate these data to see if this combination not only increases the pathologic complete remissions, but improves the progression-free survival and overall survival of these patients. So that's the phase 3 trial called Energize that's going on.
Very wonderful. Thank you so much for sharing that.
Thank you.
So now you're also a co-author on the Proof 302 trial, and that's looking at infigratinib in upper tract urothelial cancer. So can you talk a little bit about that trial?
Right. So the Proof 302 trial is a phase 3 trial looking at adjuvant infigratinib. That's a potent pan-FGFR inhibitor, oral tyrosine kinase inhibitor. This trial is looking at adjuvant post-operative infigratinib for 1 year in patients as in the adjuvant setting for not only upper tract but bladder, although it's weighted towards upper tract. Bladder, muscle-invasive bladder patients are also included. And these patients could be either post-neoadjuvant chemotherapy, or they can be without neoadjuvant chemotherapy but cisplatin ineligible. And they need to have the FGFR3 genomic alteration in the tumor to qualify for the study. So this is an exciting study because we don't have anything in this molecularly selected patient population in the second line in the adjuvant space. Of course, as you know, erdafitinib is an FGFR inhibitor approved in the post-platinum metastatic disease setting. So this gives us hope that in the adjuvant setting, you would improve outcomes and potentially cure more patients in this setting.
Good, thank you. And then there's also, I'm hoping you can talk to us about this, a 3-factor model to predict response to atezolizumab for metastatic urothelial cancer. So what is there to report about that?
Right, so we have discovered a 3-factor model in the Dana-Farber data set was a small data set of around 65 to 70 patients in which we looked at patients who got a checkpoint inhibitor, PD-1 or PD-L1 inhibitor. This was either first line or in the post-platinum setting, so any line. And we looked at multiple factors to predict regression of tumors on the PD-1, PD-L1 inhibitor. And we found that 3 factors were significant: tumor mutation burden, neutrophil lymphocyte ratio, and visceral sites of metastases. And in fact, if patients had all of these factors, it very nicely predicted whether the tumors regressed or not, with a very high C index of 0.90. So we went about to now validate this model. So we looked at the atezolizumab study, the IMvigor210 trial, which looked at atezolizumab in the first-line setting in cisplatin ineligible patients or in the post-platinum setting. So we took patients where we had tumor mutation burden and all of these variables, the neutrophil lymphocyte ratio and the sites of metastases, and we did validate the model. So these 3 factors that we found discovered earlier to be significant for predicting regression now also predict response in this clinical trial, prospective trial setting. The C index was fairly robust in the 0.75 range, and we are very excited that this could be a model that could really help us select patients or not select patients for a PD-1 or PD-L1 inhibition. That would improve the cost efficacy of this drug and the therapeutic index of this drug.
That sounds really interesting. Thank you so much.
Thank you.
Looking ahead now, it's been a really exciting few years in bladder cancer. There's been a lot of interesting advances. Where do you think we're headed now for the foreseeable future?
Right, so there have been lots of advances in the past year. As you know, back in May of 2019, we had approval of erdafitinib, a potent specific FGFR inhibitor for patients in the post-platinum setting with metastatic disease with FGFR3, FGFR2 genomic alterations. And then later in the year, in December, came the approval of enfortumab vedotin, an antibody-drug conjugate targeting Nectin-4 in post-platinum and PD-1, PD-L1 inhibitor-exposed patients. And then later came the approval of pembrolizumab in non-muscle invasive bladder cancer, but BCG unresponsive space. So that approval came in early January of this year, 2020. We also have a press release of a positive phase 3 trial with avelumab, that's a PD-L1 inhibitor, in the switch maintenance space. So post-platinum patients with responding or stable disease had a prolongation of survival with immediately switching to avelumab versus observation. So we still await the full report of that study. We also, I would mention, disappointingly have had one negative study, which is the adjuvant atezolizumab study in patients with high-risk muscle-invasive bladder cancer that got adjuvant atezolizumab postoperatively. That study was unfortunately negative. So we still wait for these data, but it's exciting that we have so many more new drugs. And looking forward, I think that the main studies that we look forward to are the frontline studies combining platinum-based chemotherapy with a PD-1, PD-L1 inhibitor. There's also studies that are combining double checkpoint inhibition, CTLA-4 and PD-1, PD-L1 inhibition that are awaited. So all of these might change the landscape. Not only that, enfortumab vedotin is being combined with multiple, in the first-line setting with the current standards of care. And we also await the phase 3 confirmatory trial of enfortumab vedotin. And if that's not enough, we also have other drugs in the pipeline, including sacituzumab govitecan, which is yet another antibody-drug conjugate that targets a different antigen, TROP2, using a different payload, which is an irinotecan metabolite. So all of these drugs are hovering in the background. So I think we have a very exciting future to look forward to.
Definitely. Thank you so much for sharing all of this, Dr. Sam Hobday. We had a really great time with you.
Thank you.
That's all for today. Stay tuned for tomorrow's OncLive News Network On Location, where we will sit down with Dr. Lawrence Albigase on the latest in kidney cancer and Dr. Matthew Galsky on more practice-changing bladder cancer studies. Thank you for watching OncLive News Network. I'm Gina Columbus.